Endodontics have changed dramatically during the last years. Due to the development of new instruments which make cleaning, shaping, and obturation of root canal systems much easier, as well as the introduction of the dental operating microscope. Based on the classic Schilder philosophy, we can enjoy today a treatment concept which guarantees endodontic perfection and predictable long-term success, if done properly. During the tooth development, Hertwig's epithelial root sheath, which is characterized by the fusion of the inner and outer enamel epithelia, determines the size and the shape of the roots of the tooth. This root sheath induces the differentiation of adjacent mesenchymal cells into odontoblasts and the formation of the intermediate cementum. If the continuity of the epithelial root sheath is broken before dentine forms, odontoblasts do not differentiate, and dentine does not form opposite to the defect. This results in small lateral canal connecting the periodontal ligament with the root canal. The inside of teeth demonstrate very complex root canal systems. Walter Hess in 1925 was the first to show these anatomic complexities with his models out of vulcanized rubber. They're characterized by multiple foramina, fins, deltas, loops, furcation accessory canals, and anastomoses. Due to decay, restorative procedures, and trauma, the vascularized pulp can degenerate into avascular necrosis. Pulpal disease normally progress coronally apically. Antigenic material and toxins then seep out of the portals of exit of the root canal system into the supporting vascular attachment apparatus. Very complex, both specific and nonspecific immune responses finally elicit the lesion of endodontic origin. Periapical bone resorption does not occur in the absence of infection. Many studies have established that the microbial flora, which eventually emerges in the root canal, is predominantly gram-negative and anaerobic. Lesions of endodontic origin are typically located adjacent to the portals of exit of the root canal system. 1/3 of these lesions are not at the apex. As soon as we have totally cleaned the root canals, with all their complexities, and sealed them permanently in 3 dimensions, the lesion of endodontic origin can heal. The longevity of a tooth is based not on the pulp, but on healthy attachment apparatus. Successful endodontic therapy is characterized by a meticulous treatment protocol. It is composed of different steps. First, there is a thorough medical and dental history, followed by a clinical and radiographic examination. Based on the diagnosis, we develop a definitive treatment plan. First, it consists of a successful pain management. After the application of rubber dam, the access cavity is prepared. Cleaning and shaping, mechanical sterilization, and 3-dimensional obturation are considered the most important steps during endodontic therapy. The endodontic therapy ends with the application of a well-fitting restoration in order to prevent coronal microleakage. The dental history is based on the following questions. What is your chief complaint? Characterize your pain. Has there been any dental treatment or trauma in the near past? Our patient complains of severe pain irradiating in the left face, which could be elicited by hot drinks. Our patient was not able to localize the responsible tooth.
Und angefangen hat es, als ich ein Eis gegessen habe.
Ja.
Ja, da war das also ganz kalt.
Ja.
Und zog also sehr lange nachhaltig.
In the clinical examination, we have to reproduce the patient's symptoms. First, all teeth on the painful side of the patient's mouth are checked thoroughly and tested for vitality. Responses to cold are within normal limits in this case. The hot pulp test with heated gutta percha was done with the specific tip of the touch and heat instrument. The teeth have been isolated with Vaseline before, so that the heated gutta percha couldn't stick on their surface. Based on the paroxysmal extreme response to heat, which was reproducible, our diagnosis was irreversible pulpitis of the first upper left molar. The X-ray shows a very deep filling and a widened periodontal ligament space on the mesiobuccal root of this tooth. The synoptic treatment plan should give a precise idea of all necessary procedures, as well as a prognosis of the treatment to the patient. In this case, it consists of the non-surgical root canal therapy of the upper left first molar, the buildup of the tooth with bonded composite, as well as a final restoration with a partial crown. Effective pain management of the patient with endodontic pain starts with the 3 Ds. Diagnosis, for example, irreversible pulpitis. Definitive dental treatment, for example, pulpectomy. And drugs, for example, local anesthetics, NSAIDs, acetaminophen opioid combination drugs. Our patient pain control is achieved by the infiltration of 2 carpules of 2% lidocaine with 1 to 100,000 epinephrine. The patient takes 1 tablet of ibuprofen right after the dental treatment. Rubber dam isolation is the standard of care in endodontics. In endodontics, we just need a basic set of rubber dam clamps. The rational use for the use of rubber dam is patient protection from aspiration or the swallowing of instruments, medicaments, or irrigating solutions. It provides a surgically clean operating field, isolated from saliva, hemorrhage, and other tissue fluids. The rubber dam clamp should demonstrate a firm fit without traumatizing the gums. In case of latex allergies, a non-latex rubber dam is available. In order to seal hermetically, the rubber dam has to be pushed through the interproximal contact point. There are clinical situations in which continuous minor leakage may occur. These often can be blocked with, for example, cavit, oral seal caulking. The aim of the endodontic access cavity is to create a straight line access to the canal entrance. Old filling material and caries have to be removed. Sometimes it's necessary to build up the tooth first. A specific preparation kit is recommended. Long-shank round burrs are used to improve the view for the operator. The initial penetration of the pulpal roof is localized in the center of the central groove, with the burr inclined slightly towards the mesiobuccal cusp. In order to get a straight line access to the mesiobuccal root canal system, the walls of the access cavity should be inclined slightly towards the buccal and the mesial. In upper molars, the typical outline of the access cavity looks rhomboidal. Studies have shown that the mesiobuccal root manifested two root canal systems in approximately 90% of the time. By carefully removing a secondary dentin towards the palatal side of the mesiobuccal orifice, a MB2 system can often be found with the endodontic explorer. In case of difficult to localize MB2 systems, different techniques can be used. The operating microscope to better visualize the anatomic footprints, such as the development grooves. They display different color and translucency than the surrounding dentin. The champagne test with sodium hypochlorite. Sodium hypochlorite sets off oxygen in contact with pulpal tissue of non-instrumented canals. The use of specifically designed ultrasonic tips. They allow the removal of restricted tooth structure with optimal visual control and very high precision. The secret to successful clinical endodontics is a proper cleaning and shaping. Cleaning refers to the removal of the entire organic substrate from the root canal system. For example, organic debris, microbes, microbial byproducts. Sodium hypochlorite dissolves organic tissue, microbes, and toxins in the root canal systems. It also acts as a lubricant and keeps the dentinal mud in a loose suspension. Sodium hypochlorite is used constantly and without any pressure. Shaping refers to a logical cavity form that any dentist can fill. Shaping facilitates cleaning. Well-shaped canals consistently demonstrate well-obturated canals. In order to explore the specific anatomy, pre-curved small K-files are used first. The pre-curving depends on the root canal anatomy. Herbert Schilder taught endodontists to think in the third dimension. His 5 mechanical objectives for successful cleaning and shaping were first introduced in 1974. A continuously tapering conical form is developed with the narrowest cross-section diameter at its terminus. The root canal preparation should occupy as many planes as are presented by the root canal system, that is, multiple planes. This objective preserves the natural curve or flow. The apical foramen should remain in its original spatial relationship, both to the bone and to the root surface, without any type of transportation. An internal transportation occurs when the foramen becomes clogged with dentin mud or denticles. Clinically, it is characterized by the loss of working length or leads to a new false path. External transportation means the tearing of the apical foramen or a direct perforation. The foramen should be kept as small as practical. The Schilder technique of cleaning and shaping will be demonstrated in the distobuccal root canal system of our patient. During the initial apical preparation, very small pre-bend flexible files are used gently to tactually feel and see with the instrument. The next step is to follow the path of the radiographic terminus and to check the patency of the apical foramen. The access cavity is gently irrigated with sodium hypochlorite. In order to avoid over-instrumentation, the length of the root canal instruments must be checked carefully. Modern apex locators measure the electrical impedance between the file and the mucosa. These devices provide accurate measurements to within 0.5 millimeters to the apex. The position of the root canal instrument is displayed on a screen, as well as acoustically. The working length can now be checked with a radiograph. In order to get reproducible, high-quality films in the paralleling technique, the so-called beam guiding instruments can be used. They consist of a large and a small diaphragm, reducing the radiation exposure significantly. The cemento-dentinal junction is not clinically meaningful and may vary histologically up to several millimeters. The radiographic terminus is used as a reference. The use of intermediate sizes, such as 12.5, is very critical, as the gap from a number 10 file to a number 15 file can be too big. The percent difference between a number 10 instrument and a number 15 instrument is an astounding 50%. This is one of the reasons for the frequent difficulty found in negotiating narrow curved canals, especially in their apical third. With the use of suitable intermediate sizes, this problem can be eliminated. During initial apical enlargement, chelating agents are used beside the irrigation with sodium hypochlorite. They act as a lubricant and emulsify the pulpal tissue. In combination with sodium hypochlorite, dentinal mud gets floated out by the effect of effervescence. In this case, the initial apical preparation is finished after a number 15 K file, which slides to the canal terminus. This is followed by the enlargement of the coronal two-thirds of the canal, called the bodywork. Due to the geometry of their flutes, reamers are more suitable than files to carve dentin and to carry dentin shavings away. Reamers are never forced apically. Reamers are for carving in relatively straight canals and the relatively straight portion of curved canals. The reamer is inserted and given only a half a turn when it first makes contact with the canal walls. The pre-curved number 20 reamer slides short of the radiographic terminus. The envelope of motion of the pre-curved reamer randomly shaves the dentinal walls. This sculpting occurs exclusively on withdrawal. The number 20 reamer slides passively short of the apical foramen. The next size reamer is inserted and given half a turn when it first makes contact with the canal walls. The stop of the instrument is adjusted to this depth of penetration. This is repeated with the next size reamer, each time adjusting the stop on the instrument up to a size 40 or 50. The canal is irrigated with plenty of sodium hypochlorite. Gates Glidden drills in the sizes 1 and 2 marry the access cavity with the canal. This essential step removes restrictive dentin and allows larger reamers to fall freely and deeper into the evolving shape. After irrigation, we recapitulate for the first time. With a probing action, we replace to the apex the last instrument which has been worked to this depth. In our case, a number 15 file. The patency of the foramen is checked. We irrigate, reintroduce, and reapply every reamer in the series previously used. In most instances, without any pressure. Each reamer can be advanced closer to the apex than in its prior use, before making contact with the canal walls and receiving one half turn. This finally creates the desired continuously tapering conical shape, developing suitable access for delicate preparation of the apical portion of the canal. Serial reaming and filing with repeated irrigation improves the angle of incidence, so that a number 17.5 file is slipping to the radiographic terminus. During the second recapitulation, no instrument goes to the same place twice. They automatically extend deeper into the canal, thus developing the desired conical shape. Gates Glidden drills are used again to brush the walls in the cervical third and to continue to blend the shape of the apical third with the coronal third. If the desired shape has not been achieved, more recapitulations are necessary. After the last recapitulation, the actual size of the foramen is explored with a K file, in this case, a number 20 file. The exact position of the file gets checked electronically and radiographically. The final apical shaping is done in a serial step-back preparation. Serial step-back preparation entails the use of a series of progressively larger instruments that are worked, or stepped back, successively further from the end of the root canal prep. Apical portions of canals are best manipulated with files. They are used with short in and out strokes in the long axis of the pre-curved instrument. Files are worked in a gentle motion, only to a depth where they are slipping and sliding passively. The multiple waves of delicate shaping finally lead to an extremely smooth tapering preparation. A non-standardized gutta-percha cone is selected that closely resembles the dimension of the cleaned and shaped canal. The cone gets cut off so that its apical diameter is slightly larger than the last file to the foramen. Cleaning and shaping are complete when the cone fits. The master cone can be inserted to full working length and upon removal exhibits tuckback. Tuckback refers to the tactile sensation of apical snugness. The cone shouldn't look crinkled after removal. In this case, the selected cone was either too small or the canal wasn't shaped properly. A diagnostic film confirms the master cone's position. Before packing, the master cone is cut back 0.5 millimeters from the canal terminus or consistent drying point. Due to their superelasticity, instruments made of nickel titanium allow also the less trained dentist to shape curved canals without apical blocking or tearing. Nickel titanium can be effectively used as a rotary root canal instrument in moderately curved root canals. Before using rotary Nai-Tai instruments, the path to the radiographic terminus should be established with the number 15 file during initial apical preparation. With this instrument, the initial length is controlled. To perform in the best way and to reduce the risk of fracture, GT rotary files are used with a constant speed of 150 to 350 RPM and a preset torque. They must be used with a very light touch. The special file design is characterized by radial lands and U-shaped flutes. The maximum blade diameter is 1 millimeter. Thus, these instruments are very well centered in the canal. Dentin shavings are carried out of the canals, while the guiding tips seek out the canal and prevents apical transportation. These files avoid the risk of over-enlargement in the coronal portions of canals, giving us predefined canal taper. The GT rotary files are used in a crown-down technique, starting with the instrument and the biggest taper, and moving to the instruments with smaller taper. This allows that only a small surface area of the instrument gets in direct contact to the canal walls, thus reducing the risk of fracture or ledging. Early coronal enlargement is important to get the files of greater taper easily and safely into the apical portion of the canal. The crown down is continued with Nai-Tai files of smaller taper. . In this case, .04 profiles in sizes 35, 30, 25, and 20 are used. Finally, small pre-curved K files are used to explore the actual size of the apical foramen. The position of the file, which slides passively to the foramen, can be controlled radiographically. The final apical preparation is done with .04 profiles of increasing size. These instruments are used only where they can safely fit, with only the smallest files reaching to the canal terminus. They are stepped back in half-millimeter increments. Finally, files of greater taper are used to improve the deep shape. In our patient, taper files of .06 are worked to the canal terminus, while the taper file of .08 is stepped back for about 1 millimeter. Now the canal has assumed the shape, and a gutta percha cone can be fitted. At the end of the shaping procedure, the smear layer is removed by irrigating the root canal systems with an aqueous solution of 17% EDTA. EDTA means disodium ethylene diamine tetraacetate. Exceptional cleaning efficacy has been demonstrated for a combination of sodium hypochlorite and EDTA solutions. This combination removes soft tissue remnants as well as the organic-inorganic smear layer, thus reopening the tubules. With the root canal filling, we try to achieve a three-dimensional obturation of the root canal system. Vertical compaction of warm gutta percha consistently produces dense, dimensionally stable, three-dimensional root canal fillings. Lateral canals are filled with extraordinary frequency. The following armamentorium is used. Shoulder plugger, the touch and heat instrument, non-standardized feathered gutta percha sizes fine medium, medium, large. Carapulp canal sealer extended working time. The essence of the technique is to capture a maximum cushion of softened gutta percha and to compact it. Pluggers are selected whose diameter is just slightly less than that of the canal at any given level. 3 pluggers are used for any one root canal preparation. They are pre-fitted to the desired length. The largest diameter plugger must work passively, unimpeded by dentinal walls over a range of a few millimeters in the coronal 1/3. A smaller diameter plugger is chosen that can work effectively in the middle third, and a smallest plugger is selected that can work easily to within 5 to 7 millimeters from the canal terminus. The master cones are sterilized in sodium hypochlorite, rinsed in alcohol, and dried with the air-only syringe. Remnants of sodium hypochlorite get eliminated and the cone stiffer. The pre-fitted master cone is slightly buttered with sealer. The sealer should be mixed somewhat thicker than the manufacturer's recommendation. Before the cone is inserted in its final position without pressure, the carefully rinsed and dried canals are covered with a very thin layer of sealer. A rubber stop is placed on the heat carrier of the touch and heat instrument so that it will be worked to within 5 to 7 millimeters from the canal terminus. The useless portion of the cone is removed at the orifice level. The largest pre-fit plugger is used to vertically pack the thermo-softened mask apically. The objective is to capture the maximum cushion of softened material and to move it apically. The probe of the touch and heat unit is activated and is allowed to plunge 3 to 4 millimeters into the coronal most extent of the gutta percha. The heat carrier is then removed along with an adherent bite of gutta percha. The plugger is stepped circumferentially around the canal while plugging apically with firm, short strokes. It soon becomes appropriate to select the next smaller plugger as the narrower portion of the canal is approached, so that the plugger never meets resistance on unyielding dentinal walls. Depending on the canal length and size, the same plugger may be used several times. Following the latest heating and gutta-percha removal cycle, a sustained vertical press on the plugger for 10 seconds will produce the final wave of condensation. This will effectively offset any shrinkage that may occur during the gutta-percha cooling cycle. The downpacking is characterized by the rhythmic heating with the probes and compaction with pluggers of decreasing size. In most instances, the apical portion of the preparation is sealed when compaction is occurring 5 to 7 millimeters from the apex. An alternative to the downpacking of the classical Schilder technique was the development of the System B. With the help of the so-called Buchanan plugger, the gutta-percha simultaneously is heated and condensed. The largest plugger is selected, which can be fitted to within 5 to 7 millimeters to the canal terminus without binding on unyielding dentinal walls, and the stop is adjusted. The System B heat source is placed in the touch mode and set to 200 degrees Celsius and used in full power on grade 10. After the melting of the cone with the tip of the Buchanan pluggers in the pulp cavity area, the activated plugger is driven through the gutta-percha in a single motion to a point about 3 millimeters shy of its apical binding point. While maintaining apical pressure on the plugger, the button is released, and the plugger slows its apical movement as the plugger tip cools. After the plugger stops, about 1 millimeter from its binding point, apical pressure is sustained until the apical mass sets, about 10 seconds, taking up any shrinkage that occurs upon cooling. Maintaining apical pressure, the plugger is activated again for a 1-second surge of heat to separate the plugger from the gutta-percha at the apical area. Coronal gutta-percha debris can be pulled out very easily using rotary Nitai instruments. A periapical working film taken at the conclusion of the downpack checks the three-dimensionality of the packing. In this state, another wave of compaction can be done to improve the apical corkage. On the basis of the physical properties of gutta-percha, the heat penetrates apically about 5 to 7 millimeters deeper than the heat probe or the Buchanan plugger. On the basis of its thermoplastic characteristics at 41 degrees centigrade, it fills and seals areas of complex anatomy. Afterwards, the root canal system is filled step by step from apical to coronal with gutta-percha. The best proven system for this technique is the Obtura 2 gutta-percha gun. With this system, you can apply and condense thermoplastic substances in short portions. The hot, pre-curved needle is inserted into the canal until it comes into contact with previously packed gutta-percha apically. Pluggers are used for compaction. Through a series of gutta-percha injections and vertical compactions, the canal is filled completely step by step. The hot tip of the needle will resoften the most coronal aspect of the apical core of gutta-percha, ensuring cohesion and homogeneity during backpacking procedures. Ideally, the tooth is built up immediately following the endodontic treatment by means of a bonded composite restoration, if enough tooth structure is left. In this way, it is ideally prepared for further restorative procedures. This is done in a total etching technique, followed by suitable dentin bonding agents. The tooth is checked for any interferences during centric occlusion and excursive movements. Coronal microleakage is considered a very important reason for endodontic failure. Therefore, a high-quality restoration is of utmost importance to finish the treatment successfully. Together with the proper oral hygiene and periodic recall, this treatment concept offers the best basis for permanent dental preservation.